So good afternoon, everyone. My name is Jennifer Yost, and I am a knowledge broker with the National Collaborating Center for Methods and Tools. I would like to welcome everyone here today to our Spotlight on Methods and Tools webinar series on the Consolidation Framework for Implementation Research, Application, and Tools. So just a few housekeeping items for those of you who it might be your first time joining us via WebEx. We would ask that you post all of your questions and comments into the Q&A section at the bottom right-hand corner of your screen. And just be sure to say send questions to all, although if you do make the slight error of sending them privately to post, we will receive them. There will be a question and answer period at the end of the webinar. We're aiming hopefully for a little after 2 o'clock to give us some time to hear your comments and questions. And so I will be posing the comments and questions that you have posted in the Q&A to Laura to answer. So as you may come up with questions or comments throughout the webinar today, please feel free to type them in during the webinar, and we will have Laura address those towards the conclusion of her presentation today. And just a reminder, we would suggest using a wired internet connection versus wireless. And if you do have any questions or need any assistance with the WebEx software itself, there is a 24/7 helpline that we have indicated in the chat section of today's webinar on the right-hand side. For anyone who might be experiencing issues with their internet access itself in WebEx, we would suggest possibly using Google Chrome in order to have the best platform with WebEx today. So just our first polling question, we'd like to try and get a sense of where everybody is from. So if you could just let us know which province or territory, or if you're outside of Canada. And as I see people are starting to respond, we have some people joining us today from British Columbia, Alberta, Ontario, with the majority of people at the moment being from Ontario, and we have a few people joining us from outside of Canada. So really exciting to have some international colleagues joining us today. So we'll just give a few more moments for people to get in their response, and then we will move along. So this is a webinar in our series which focuses on methods and tools located in our registry on the National Collaborating Center for Methods and Tools. And this, as we've mentioned, is a series, and we like to spotlight different methods and tools within the registry. And this is our 20th episode or 20th webinar within this series. So thank you to anyone who's returning participant to our webinars, and thank you to those of you who are new joining us today. We're quite excited about being able to share knowledge with those who might find it helpful to use in their practice and decision making. So for those of you who may not be familiar with the National Collaborating Center for Methods and Tools, it is one of 6 collaborating centers funded by the Public Health Agency of Canada. So as you can see, the 6 centers are across the country. We here at the National Collaborating Center for Methods and Tools, or better known as NCCMT, are located in Hamilton, Ontario, and are affiliated with the School of Nursing at McMaster University. While 4 of the National Collaborating Centers support the use of research evidence in specific public health content areas, such as infectious diseases or environmental health, here at NCCMT and also at NCC Healthy Public Policy, we work across content areas. And at NCCMT, our focus is on improving access to and the use of methods and tools that support moving research evidence into decisions related to public health practice, programs, and policies throughout Canada. So while we do have a very large registered user base throughout Canada and internationally, primarily in public health, but also in other content areas. Our focus is, as you will see, focused on the public health practitioner. So another polling question for the audience today, for those of you who have joined us, trying to get a sense of what sector that you're from. Public health practitioner, a health practitioner in another field. Do you work in education, research, for the ministry, a specific municipality, or with a national government organization? So we are finding that, I'm looking at the polling questions, and it seems that we have some people working in research joining us today, which is great. A few public health practitioners, some working for the provincial, territorial government, or ministry. So thank you to all of you who are providing responses. We also have people joining us today who work within education, but it does seem like, looking from your responses, and which will be helpful for our presenter today, that most of the attendees today are working within the research sector. So it is my pleasure to welcome today's presenter, Laura Damschroeder, who is a research scientist at Ann Arbor Veterans Affairs in the Center for Clinical Management and Research at the HSR-ND Center for Excellence. So we will decide if we'll count Laura as one of our international participants, but it is wonderful here in Canada to be able to share the work that our colleagues are doing throughout the country, throughout other countries internationally that may be relevant to our work in Canada. So today's webinar will focus on the tool that Laura Damschroeder developed, and it is one of the products and tools that is located within our registry of methods and tools. And as you can see here at NCCMT, we offer a variety of products and tools which, again, are aimed at helping those working in public health to use research evidence in decision-making. So in addition to tools such as the one you will hear about today, which are available open access in our registry of methods and tools, a searchable database. We also have some online learning opportunities through our learning management system, which houses our online learning modules. And we are working on building up our using research evidence in practice videos, so multimedia videos, to help explain some difficult concepts when it comes to understanding some of the numbers and concepts within using research evidence in practice. So it is my pleasure now to turn over today's presentation to Laura, and I will be coming back online to facilitate some more of the polling questions that we have throughout the presentation. And again, I will be back on at the end of the presentation to facilitate addressing your questions and comments that you have for Laura today. So, Laura, over to you.
All right, thank you. It is my pleasure and privilege to be able to talk with your group today. Thank you so much for taking time out of your busy day to attend this webinar. As Jennifer said, that my focus, of course, will be on the Consolidated Framework for Implementation Research. And I'm going to try to give you an overview and then also get into concrete examples of applying that framework, and then also the tools that have been developed or else are in development. I may not have the ball. I'm trying to, whoops, I see that I do have the ball. Okay, now it is. So I have my first poll question. And I just wanted to get a feel for your familiarity with the CFIR. And perhaps you just say, what's the CFIR? Basically indicating that you really don't know very much about it. You may have some familiarity with the CFIR, which is the second option, or you've thought about using it in your work, or none of the above.
So as I am looking at the polling questions, and we apologize due to the WebEx system itself, we're unable to share with you the results in real time. But Laura, it seems like we have a very good split between A, B, and C, almost an even split today with those participants who provided us answers to your question today.
Okay, good. That's good to know. So then the next slide, this is my outline. Basically, I'm just going to kind of set the stage by talking about the goals for implementation research and how using a framework like the Consolidated Framework for implementation research can help meet those goals. I'm going to describe a case study that used the CFIR, and then how the CFIR or a comparable framework can help to build the knowledge base for implementation science, and implementation strategies, linking in implementation strategies, and then just kind of a roadmap for the future. So I really believe that there are two really fundamental dual goals for implementation research, and that because of the sphere that we work in, those of us who focus our science on in the area of implementation, that it's really important for us to do it in a way that advances science, in other words, being collaborative, building knowledge, the knowledge base systematically. We're studying a very complex phenomena in terms of the context in which we do our work and the fact that we embrace the complexities of that context, and then plus the interaction of the strategies that we use to accomplish our, excuse me, to accomplish our implementation goals, as well as understanding the context under which certain strategies may work and or not work. But then also the praxis or the practical side of the coin. It's really important for us to pay attention to as scientists in developing tools and processes for practitioners to use so that we can turn over our knowledge as quickly as possible into the hands of people who actually need to do sustained implementation of new programs or innovations. We need to be able to identify effective strategies and to give guidance for how to tailor strategies to context, to basically answer the question of, well, what will work in my setting? What will work in my hospital or in my clinic or in my community? And then really, I think that in implementation research, because of our focus, we're, I think, uniquely positioned to contribute to the culture of the learning healthcare system. And here in the U.S., there's a lot of talk and desire to kind of move to this idea of a learning healthcare system, and I would imagine elsewhere and in Canada as well. So I want to make a case for the use of theory. Theory is not of course it advances the goals of science, but I would also suggest that the use of theory in a systematic way is also very practical. In fact, there's an article that I really enjoy, and it's called, There's Nothing So Practical as a Good Theory, and I really believe that. But the reason is that it provides an organizing framework for research studies and also implementation efforts. It helps to build a scientific knowledge base so that we can better understand context and mechanisms of actions within those contexts. It gives us the ability to generalize through theory because in implementation, our unit of analysis is not individual patients, for example, but it tends to be organizations, so collectives or groups or teams of people. And that means that our sample sizes are necessarily on the small side because it's very difficult to accrue and to really study thoroughly massive numbers of organizations. And then it also allows us to synthesize across studies. And this is really important, again, because of the small to medium sample sizes that we tend to work with, so that we can have consistent common terms and definitions across studies and settings that are reported and that are shared. And so in this way, it really can be an efficient way to systematically build collective knowledge about implementation over time. So now I have another poll question, and I'm wondering which of the following responses best describes your work? Do you tend to develop and test new innovations, for example, to improve patient health or well-being? Do you develop and test implementation approaches? Do you actually implement, so more as a practitioner, or do you do some of all of the above or something else?
Great, thank you. And I am seeing that most of the participants are either answering developing and testing implementation approaches, or D, all of the above. A few people have started to answer developing and testing innovations and implementing innovations, but I think for the most part of those who have provided responses, and thank you for those of you who are providing responses, most are developing and testing implementation approaches and doing all of the above.
That's wonderful to hear that you're really working in multiple spheres, and also with the focus on implementation approaches. So when we do work or research to develop new innovations to, for example, improve patient care or improve the lives of individuals within communities or students within educational settings, I heard that some of you work within the education sphere. The goal of this kind of work is to improve the health and well-being of patients, or let's say the learning or to achieve learning goals for students, for example. And it's really important for us to be able to understand what the active ingredients or the active components are that contribute to the benefits that we observe. And then how can we adapt those innovations into diverse settings in a way that maximizes or achieves those same benefits that maybe we get in a controlled trial. Often in these tests, which include randomized control trials, for example, either efficacy trials or effectiveness trials sometimes, we tend to ignore or attempt to control or perhaps ignore the role of content within these studies, because the focus is on internal validity and to establish that causal pathway to the innovation actually being the contributing to or causing the benefit of interest. So for example, in terms of identifying active components, in our own work, we recently published results of the ASPIRE weight loss trial. It was a comparative effectiveness trial. And we also published a paper on a fidelity instrument that was used to assess the delivery of the weight management coaching to patients. And we found that all of the dimensions of fidelity in terms of the coaching delivery of this intervention, for example, staying on track, modulating distractions, building empathy, delivering the psychosocial educational components, that fidelity to those components resulted in more weight loss. And so the higher the fidelity scores were for each of the subscales, the more weight loss the participants experienced. And in particular, one, that subscale that we called staying on track, which means modulating distractions and focusing kind of on the topic that it was being emphasized in each of the sessions, that resulted in the highest amount of weight loss independently in and of itself, almost 3 kilograms of weight loss for each 10-point increase with that particular dimension. This kind of information can be used to adapt, in this case, a coaching intervention in a way that preserves and really puts attention on, for example, delivering and helping coaches to stay on track when delivering a behavior change intervention. We also use some of the same or an adapted version of this fidelity instrument in another diabetes prevention program, comparative effectiveness trial, and these results have not yet been published and we're still in the analysis phase. But so preliminarily, we are finding that higher scores for fidelity, again, for the coach delivery of the diabetes prevention program is associated with higher weight loss and higher weight loss outcomes. And in this particular study, we actually were able to affirm measures of patient satisfaction that are not exact, but at least related to those same dimensions, and that the satisfaction from a patient perspective was also higher. And as a result of this work, the national weight management program called MOVE within the VA system in the U.S., that their program guidance was updated to try to bring their program more in line with the components of the diabetes prevention program. So this is just an example of how information about the active ingredients that contribute, or identifying the ingredients or the components that most contribute to the outcomes that we're looking for, that information can be used then to create recommendations at a policy level for program delivery. In the literature at this stage, the reports of randomized controlled trials, whether efficacy or effectiveness or comparative trials, really, on the whole, do not provide sufficient information to tell us about the active ingredients. And the other side of the coin to having high fidelity, as I've been mentioning, is guidance about how to adapt programs to maximize benefits, and that we really need to see more reporting about what components are being delivered, what components are associated with outcomes within the literature to help practitioners in the field. Then when we move to the point of, so we may have a theoretical model for the actual, in this case, a behavior change coaching intervention, but then we may also have theories about how to implement those programs. And our focus in these studies is really in preparing for and explaining implementation of those programs. And our focus will tend to be on understanding barriers and facilitators. In other words, what are the moderators within the context, that may affect our ability to be able to deliver the innovation in a way that maximizes benefits for participants. And then we also want to understand, why did it work, why will it work, or either prospectively or even retrospectively reviewing and understanding why it did or did not work. And we do this, as I alluded to earlier, as in the sphere of implementation research, and in all of its wicked complexity, because the context, there are many layers. There are individuals, there are teams, there are service lines within a hospital, let's say. There's the overarching hospital, there are healthcare systems, and then there are national policies that all kind of influence and interact with one another across levels, let alone within each of the levels, within a clinic or within a team and so forth. And so it is highly complex phenomenon that we're studying. So in just kind of walking through the role of theory in this implementation, this work in understanding the process and the context within which implementation occurs, the first step is that we can use theory to guide our assessment of context. And here I'm going to present a case study that has been published. This is related to the MOVE Weight Management Program, which is a national program within Veterans Affairs within the U.S. Some of you may be familiar with our published paper. But in that paper, we describe, it's a small study, and there were 5 sites that we studied that together across the 5 cases had a wide spectrum of enrollments. And so our outcome for implementation, our implementation outcome in this particular study, was the rate of enrollment into this weight management program of candidate patients. And so it really is a measure of what's called penetration. So to what extent, how robust is the weight management program? And that was our outcome that we looked at. And we wanted to compare and contrast sites that had low enrollments or low penetration versus those that had high or high enrollments or high penetration. And so, like I said earlier, our outcome of interest is penetration. And this is a figure from Enola Proctor and colleagues' paper that does a nice job of kind of listing all of a series of implementations. It's not exhaustive, but it's a nice explanation of different implementation outcomes. And we really need to be very, select our implementation outcomes that are most proximal to the implementation efforts. And so then our question is, as we're applying this theory, is identifying who, in order to successfully and in a sustained way implement, in this case, a weight management program, who needs to do what differently and what barriers and facilitators need to be addressed for successful implementation. And so this is a question that the Consolidated Framework for Implementation Research can help to elucidate. There are other frameworks, too, that have been published, and I do want to recognize that. But, of course, my example will be focused on the CFIR, which is a comprehensive framework to promote consistent use of constructs that are thought to influence implementation, and to provide common terminology or consistent terminology and definitions for those constructs. There are 5 different domains within this framework, and there's a total of 39 constructs and subconstructs that are organized within each of those 5 domains. So this slide is actually courtesy of, I have to give credit to Dr. Melanie Barwick, who is from Canada in Toronto. And I really appreciated this picture. Unfortunately, the animation isn't working on these slides, which is fine. But if you start from the left and see that there's this kind of poor individual practitioner, it could be a practitioner, it could be a champion, an implementation leader, someone who has really taken it upon themselves, who is either responsible or has taken it upon themselves to enact a process of implementation of a new program in their clinic or in a community or wherever your setting may be. And there are constructs. This is one of the domains of the CFIR, is individual characteristics. So what are the knowledge and beliefs of those particular practitioners that we're hoping will use the new program? What are their stage of change? Well, how much, what is their self-efficacy in terms of their confidence in being able to use this in their workflow? And then there's the innovation itself. What are the characteristics of the innovation? How complex is it? What is the evidence base, or what is the perception of the evidence base for that innovation? Do the local stakeholders, in particular leaders and other influential opinion leaders, for example, do they believe that the innovation, if it were implemented in their clinic or other setting, that it really will be better for their patients or students or whoever your focused population is? So then the champion or the implementation leader then has to go through all of this terrain of within the inner context or within the inner setting. There are, pitfalls, and these are really kind of the barriers or a representation of the barrier, real world barriers. And the outer context, the green circle outside of the rectangle box, the white rectangle, represents the outer setting, and there are several constructs related to the outer setting that may influence also the ability to implement a new innovation, including things like payment mechanisms or patients, what they bring to the table in terms of their needs and the resources that they have available to them in order to be successful participants in a treatment or in a program. Within the inner setting, there are several constructs. Actually, the majority of CFIR constructs describe the inner setting. So, for example, one construct is leadership engagement. To what extent do leaders, organizational leaders, support and engage and are committed to implementing the innovation? And there are many studies that find the importance of having leaders ideally commit and support and visibly support the implementation process, or at least in some of our work, it's at least that they get out of the way, that they don't create blockages to the implementation process. So that's an example of just one of the constructs within the framework. The 5th domain is the process domain, and process includes consideration of planning. Is there a plan? How formal is it? What is the quality of the planning? What is the quality of execution? And then there is the construct related to engaging. Are you engaging the key practitioners, let's say, or patients? And then is there an active champion? And there are several other roles in that. And then the last construct within the process domain is reflecting and evaluating. And this is evidence whether or not the team who's responsible for implementing the innovation, are they taking the time to really reflect and collect information about how the implementation process is going, and to reflect on problems, come up with, create new solutions, update your plan, and so forth. But taking the time to kind of reflect about how the process is going and monitoring that process. So this is just a little excerpt of the actual framework within our published paper, which I've got the citation at the bottom of the slide here. There is an additional file that gives you kind of a cheat sheet, front and back listing of all of the constructs within the CFIR. And the idea is that each of these constructs are often closely related to one another, but they have at least conceptual definitions that make them mutually exclusive, so that it provides a way of articulating these very complex dynamics that occur, that we all see occurring within our own context or the context that we're studying. So now I have a poll question for you. And I'm curious about what types of data do you typically rely on in your work? Do you primarily use qualitative data, for example, relying on transcripts of interviews or field notes? Or do you use primarily quantitative data through surveys, let's say? Or do you use a lot of both or neither?
Great, thank you, Laura. And just while everyone is going to participate in the polling question, thank you. I have posted the link to the article that Laura just referenced on the previous slide. There is a link to the open access article in Implementation Science posted now in the chat if you would like to have access to that link. So as I see everyone who is answering the polling questions, and thank you, it appears that the majority of people are doing a lot of both. Then followed by quantitative, and then followed by qualitative. So a lot of the both wins, followed by quantitative data and qualitative data.
That's really great to hear that people are relying on both sources because, again, I think that because of the complexity of what we're studying, that there is a really important role for qualitative data. But then the use of quantitative data, of course, is much more efficient, and there are definitely advantages. We can do, more direct hypothesis testing, for example, with quantitative data. So both kinds of data sources or types of data have strengths and weaknesses that they bring to the table, and the use of both of them I think really creates kind of knowledge, a level of knowledge that's greater than the sum of the parts. So in terms of, I'm going to first talk about the use of qualitative data through, you could use interviews of key stakeholders, what I call artifact data, which is basically analyzing or understanding already pre-existing policies and procedures, for example, maybe keeping journals or diaries as a part of the implementation process. How are things going? What are you doing? What are the activities? Did they work? Meeting notes. There are people who do ethnographies in terms of embedding themselves within organizations. And then we actually have a process for quantifying ratings based on qualitative data. Our website, which many of you may already be familiar with because of the work of the center that is sponsoring this webinar, but it is, if you go to cfirguide.org, it is available and open to everyone to use, and you'll find a list of all of the CFIR constructs along with several tools that are available. One of the tools is an interview guide maker, and what this does is you can go in and select by domain. So this is the list of all 5 of domains that comprise the CFIR. And so, for example, if you were interested in a construct within the inner setting, you would click on that, and then it would expand into so that you could see a list of all of the CFIR constructs within the inner setting. And let's say that you're interested in leadership engagement, that construct within readiness for implementation. So actually leadership engagement is a sub-construct. Then we have a couple of questions. There may be more actually off the bottom of the screen, but we have a couple of open-ended questions that we've used in our studies or that we know of that others have used that are as aligned with the definitions for this particular construct. And you can take a look at those questions and check the box on the questions that you think would be most useful for your particular project. And you can likewise step through multiple constructs and just keep selecting and then choosing the questions that you would like to include in a master interview guide. And as you work your way through that, you can create actually a formatted interview guide. And one of the things to notice is that along with the primary question, there are also prompts, qualitative prompts that can be used in conjunction with each of the many, not all, but many of the primary questions. And so you can cut and paste this into a Word document. You can adjust the tense as you need to, for example, past versus future tense. And you can reword and adapt the questions to fit your particular needs. So this just provides kind of a starting point for creating an interview guide. And often when you're writing proposals, the reviewers want to see example questions in an example interview guide, so this would help with that. In terms of quantitative measures, I'm just doing a quick sidebar here. We're not very well developed with quantitative measures, and I think that part of the reason for that is that, again, what we're studying is highly complex, and there are a lot of conceptualizations of exactly how to measure and what aspects to measure. And there was a paper published in 2014 that just kind of gave a nice overview of the issues and gaps, lots of opportunities as researchers. There are several researchers on this call to kind of contribute and to fill those gaps. There are one paper by Chaudhry, for example, and colleagues published in 2013 provides a very wide-ranging synthesis of measures or a listing of measures and kind of characterizes those measures, which is very useful. And there are also other, this is not the only paper, but I just offer it as an example. And then there's a process going on right now by the Society for Implementation Research Collaboration. I have the website there. And they are assessing instruments that are related to the CFIR and related to the earlier outcomes framework that I showed you on an earlier slide, the one that was published by Anola Proctor and colleagues. And actually just recently, and I need to update this slide, this group led by Kara Lewis and her colleagues just recently published a paper about the measures related to implementation outcomes. They have identified, this group has identified over 400 different measures, and they have these all listed on a website. They've got the inner setting measures listed and then the implementation outcomes measures listed on their website, and I highly recommend going and checking that out. There are also several efforts underway to develop quantitative measures. So the earlier example that I gave you was a synthesis of already existing or published measures. There are also efforts to create new measures or perhaps kind of further developing from existing measures. But for example, last year at the Dissemination and Implementation Conference in the U.S., here in the U.S., Maria Fernandez and Michelle Kiegler actually both each presented a paper there where they had quite a comprehensive list of measures that were tied to the CFIR. But I don't think that this work has yet been published. On our website, I will also say that we have done some mapping in a relatively kind of small group of experts where we've gone very in-depth with 2 different instruments and mapped the individual items of these instruments to the CFIR constructs. So that's another resource that is on our cfirguide.org website. So this is just an example of one construct that we call networks and communications, which is acknowledging the importance and the influence of the nature and quality of working relationships between professionals within the setting, and then also the communications as well. So in our particular, getting back to our case study, and I've got the citation of this paper at the bottom of this slide, where we were assessing the MOVE weight management program within Veterans Affairs here in the U.S., we found that the high implementation sites, or the sites that had the best outcomes, had a high degree of teamness. And by this, we mean that people had very high quality pre-existing and also continuing to build on those relationships. And they met regularly, and because they met regularly, that was one of the reasons that their working relationships continued to get stronger and more productive. At the low implementation sites, they did not have regular team meetings. They said that they basically met through email, which is basically not meeting at all. And they did not have effective communications going on in their organization, to the extent that even patients were confused about what it was that they were being referred to. Within our particular study, we used a qualitative or an interview guide using the CFIR, and we that was guided by the CFIR, and then we coded the qualitative data using CFIR constructs as kind of our code book. We took it a step further and we rated the strength and the valence of each construct. So, for example, the strong influence, the strong positive influence of those strong networks and communications that we found in the sites with the best outcomes, they would get a +2. So where we had passages that were coded with networks and communications, and those that showed a strong positive presence of that, we would code as a +2. If it was a weak presence, it would be a +1. If it was neutral, a 0. If it was weakly negative, then it was a -1, and strongly negative, it would be a -2. And I'm not going to go into too much detail in that, but we do have a lot of information about that on our website and also in our published paper. So when you quantify qualitative data in this way, we can create a matrix then that allows us to compare and contrast the high and the low implementation sites. So in this case, I circled kind of a really obvious pattern, which we don't always get, needless to say. But for networks and communications, we found that the low implementation sites, or the sites with the lower outcomes, had strong negative effects of networks and communications, but the facilities that had high or strong implementation outcomes had a positive rating, strong positive ratings for networks and communications. And we do this for each of the constructs that we evaluate. So then we also applied the same technique to another project, and this was also a lifestyle change project, our intervention with coaching, but this time over the telephone rather than in person in groups. And also in this study, we had more cases. We actually had 11 cases. Which still isn't a very large sample size, but it does allow us to be able to see these patterns with a little bit more confidence. And in this case also, we selected sites with high, medium, and low implementation outcomes. And in this case, because we had 11 sites, which even though it's not a very large sample, we actually were able to do correlations of our ratings across with implementation outcomes. And in this particular study, the analysts were blinded, so they did not know what the implementation outcomes were for the cases that they were analyzing, and this is important to keep in mind as you're applying the ratings. In this case, if we were to take one CFIR construct, and this is compatibility, just as an example, And this construct recognizes the importance of the compatibility of the new program with existing programs. And in this case, across the 11 sites, we had a correlation of 0.55 of the ratings for that construct of compatibility and with implementation outcomes. And it was marginally significant in terms of statistically, but again, because the sample size was so small and the correlation so large, we considered that this particular construct at least weakly differentiated between the high and the low implementation outcomes. And looking back at our qualitative data, we can see that what does this mean? How does it manifest? What does it look like with respect to this particular program within these clinics? And in places that had negative ratings for compatibility, only providers, only primary care physicians could refer to the new program called TLC, and nurses could not, for example. They were forbidden to write orders. And so this really kind of provided a choking point, in a sense, of not being able to refer very many patients to this particular new program. So it kind of stymied or blocked their efforts. And whereas in a site with a strong positive rating of compatibility of the new program with existing programs, multiple clinicians were able to refer patients to this new program. And they really felt that it blended in very nicely with already existing health coaching programs. So they didn't see it as a competition. They were already doing health coaching, and so they understood they had a process basically for referring patients to the program, which helped make them successful. So now these were our approaches within individual studies, but how can we build on these findings across studies? Well, one way we can do this is, like in the discussions of our papers, tends to be a little bit less formal, or even formally, if we, this matrix shows results of 3 different studies that all use the CFIR. So we're all speaking the same language, and we're all using similar analysis and coding approaches to qualitative data guided by the CFIR. And in this case, across all 3 studies, and I just highlight this as one example, that the positive or that the effects of networks and communications, either positive or negative, seemed to be related to implementation outcomes within each of 3 different studies for 3 different lifestyle change programs. And so in this way, we can start to see patterns. Under what circumstances might a construct be important for outcomes, and in other circumstances, maybe not. If we start then really expanding our repository of results, then we can start really building a lot of cases across multiple studies that have all used kind of comparable approaches. And this gives us the ability to use what's called qualitative comparative analysis. And this is just one analytic approach that is being increasingly recognized as a potentially powerful analytic approach to that basically embraces causal complexity, the kinds of complexity that we see within implementation research. It acknowledges that there's equifinality, meaning that there's more than one way to be successful. So there are different combinations or different recipes. And using QCA, qualitative comparative analysis approaches, we can discern or identify what those recipes might be. There's also, it also embraces or recognizes conjectural causation, meaning that these conditions or constructs may not exert influence on outcomes independently, but rather in conjunction with other constructs. So kind of, again, getting back at those recipes. And then there's asymmetrical causation, the fact that the absence of something does not necessarily mean that you will not be successful, even though the presence of something does appear to be associated with success. So in qualitative comparative analysis, it takes a case-oriented analysis approach rather than variable-oriented, which is what most of the kind of the more traditional regression modeling or hierarchical modeling approaches are, that they basically take a variable-oriented approach. And QCA is based on set theory and Boolean algebra. And again, it's very appropriate for the implementation sphere because we are interested in cases. Why is one case successful and another case not? And it allows us to evaluate different configurations of conditions across diverse cases. And the number of cases doesn't really matter on this. You may hear, if you've heard of QCA, you may hear people say that it's great for small sample sizes, but it also can be good for large sample sizes as well. There really is no limit on the size of the sample. In our repository, we have a repository of 7 different studies that together create a database of 53 cases, which is still a relatively small sample, but much larger than each of the individual studies. Most of them were implementations of behavioral change programs, but we also had specialty care programs as well, and then a teleretinopathy program. So there were this is a fairly diverse set of innovations that are being implemented and being evaluated using the CFIR framework. So they had that in common across all 7 studies. I will note, however, that all of these studies did occur within the VA, and I think that's important to keep in mind because while they are diverse, they're not diverse with respect to different policy settings or different national settings that you may get in different countries. But what we've learned by looking at doing a series of qualitative comparative analyses based on this repository of cases is that there is definitely causal complexity. We have identified many different pathways that do lead to success. Because not all of the studies are all evaluating the same set of constructs, we have a lot of missing data. And the missing data really limits and changes the combination of cases that can be included in each of the individual analyses. And depending on the cases that are included and the constructs that are in the analysis set, we come up with different solutions or different recipes. And so that in and of itself is really interesting, but also speaks to the complexity of this analysis and also the need to continue growing this repository so that we can start to triangulate into consistent understanding of what works in what situations. So now we come back to our focus on preparing for and explaining implementation, and in the literature, we do not have sufficient reporting of contextual factors so that we can really apply and generalize or transfer knowledge from one setting to another. Even though I think we all agree that it's important to understand those barriers and facilitators and why an innovation works in one setting and not in another. So now the next question that we want to address is understanding what strategies to use to address barriers and facilitators, or another way of putting this is what strategies are best in which settings. So we want to be able to tailor strategies based on the particular context or features of that context. So for example, if we were to look at the CFIR construct that we call goals and feedback, and this is a construct that recognizes the importance of, first of all, articulating organizational goals or goals for a specific implementation, and then providing feedback, providing data about how you as an individual or you as a program or a team contribute to progress towards that organizational goal. In our own work, we find that many individuals are challenged to be able to track their own program data. In the case of the weight management program, being able to track weights is pretty important, but they often aren't able to do this, or if they do, it's kind of trapped in a spreadsheet and they're not really sure what to do with it. and putting it together in a way that helps to inform how they could improve their program. So change strategies, one strategy might be audit and provide feedback and putting those kinds of systems in place, or other quality monitoring. In our own case analyses, sharing anecdotal success stories about patients was very effective as well. A current effort, there is a series of actually 3 papers now that have been published in Implementation Science that include many of the same authors that are on this slide here with a snapshot of the paper. But it is the Expert Recommendations for Implementing Change, or the ERIC strategies. And this work has extended on work from Byron Powell and colleagues that published a paper that compiled a list of implementation strategies. And then the ERIC work expanded on that list to create or identify a list of 73 different organizational strategies that can be used to facilitate implementation. And a concept mapping approach with many experts was conducted, and this is just an example of actually the final kind of concept mapping that was developed. And those 73 strategies were clustered into 9 groups. And I won't go into the shapes or the particulars of the concept mapping itself, but this is just to show how those 73 strategies cluster together into different groups. And one example structure, cluster is called our strategies that are related to providing interactive assistance. And there are 4 different strategies that are in this cluster: centralizing technical assistance, facilitation, provide local clinical supervision, and provide local technical assistance. So these 4 strategies all were in a similar kind of cluster of approaches that could be used to facilitate implementation. So what we wanted to do, and we just completed, we're actually in the analysis phase of a study where we asked a range of experts, and we had 169 people who responded to a survey. Maybe some of you responded, and for that I thank you very, very deeply, where we asked people to look at a barrier. We defined a barrier within a context, within a contextual barrier that was defined based on the CFIR. So for example, evidence, strength, and quality you can see in the left box on this slide. And what happens if stakeholders have a low perception of evidence, that in other words, they don't really believe in the evidence base, or that they believe that the evidence base is weak for the innovation? What are ERIC strategies or implementation strategies that could be used to address that issue? And so one is maybe building a coalition. So you look over in the blue box, and some of the experts identified building a coalition as a way to overcome people's perception of weak evidence for the innovation. And in this way, you see this kind of spider web of relationships occurring as each CFIR barrier may have, and what we're hoping to create is a shortened list of strategies that experts may recommend for addressing a particular barrier. So what we did is we asked respondents to this survey, and this is an example related to goals and feedback. And here the barrier is goals are not clearly communicated or acted upon, nor do stakeholders receive feedback that is aligned with goals. And so this is a barrier, a stated barrier. And what we asked is for the respondents to look at the list of 73 ERIC strategies and to choose 7 that are that are most likely or best able to address that particular barrier. And in this example, if the slides were automated, you could see how the person can drag and drop audit and provide feedback, just as an example, into the rankings box. And so the experts basically chose the top 7 and then ranked those 7 as being best able to address a particular barrier as defined by the CFIR. So what do we do with this information? Going back to the CFIRguide.org site, we actually have a mock-up of what a tailored strategy tool might look like. And what we hope to do is to use the information from the survey that was completed this summer, and kind of like the interview guide maker, where you go in and select the CFIR process or the CFIR domain, in this case, just an example, going into the process domain. And let's say you're interested in what ERIC techniques can be used to improve reflecting and evaluating. And then we have a list of recommended strategies that would show up, and you can check the box of any of the strategies that you think you might like to try within your context. And so what we've done is basically narrow down, 73 different strategies into maybe a dozen or less, or a couple of dozen strategies. And in this way, you can keep clicking through. This is what we're envisioning for this tailored strategy tool. And when you've completed all of the barriers that you want to address, then you would create a document with a formatted set of strategies that can be used as a starting point or as a foundation for creating your implementation plan. So now kind of closing the loop with applying theory. So once we understand what techniques can be used to address barriers and facilitators, and then measuring progress along toward those implementation goals and creating a tailored implementation strategy, then we want to execute that strategy while ideally doing it incrementally. And then evaluate the effectiveness of that strategy in the end. And again, it's important at this phase or prior to this phase to identify the outcomes that are important for your particular efforts. And implementation methods can help to inform outcomes, assessing outcomes at many different levels. And then it's really important to assess the fit of your findings with the initial theory. So in the case of the CFIR, for example, was the CFIR helpful, and how does your work add to the knowledge base, and really kind of closing the loop on that. And this is an example paper by Irene Ellett and colleagues where they did an assessment of the CFIR in terms of its feasibility, its usefulness, and its comprehensiveness, and actually critiqued the framework and had suggestions for improving it, which is really helpful and important, I think, so that we can continue to refine these kinds of frameworks and thus our theories. So in terms of the overall kind of a roadmap for implementation science and the role of frameworks in being able to move us forward, that a framework like the CFIR provides common terminology and constructs and language. It can provide, it can guide assessments of context quantitatively or qualitatively. Targeting innovations, it's important to identify the exact components in the innovations being implemented and how they're adapted into local settings. And then to identify the implementation strategies that are tailored to address specific issues or potential barriers within context. And then ultimately, to advance science is to be able to generate testable theories. And then addressing kind of our second goal, I think, for implementation research is how do we package what we learn for the real world? And really, practitioners need to have guidance that we can provide for planning successful implementations. And our group, and I know many others also, are in the process of developing and testing context assessment tools that are very practical, which means, frankly, that they need to be brief and easy to use, which is a real challenge. and then to give guidance for how to execute strategies to implement, and then how to tailor them to local context, and then creating these learning repositories that actually help both the scientific community and the practitioner communities to support collective learning. So that's all I have, and ultimately we want to answer the question of what works where and why, and be able to understand answers to that prospectively, ideally. Thank you.
Great, thank you so much, Laura. And we have just opened up another polling question here asking about what your plans after today's webinar will be, and just asking you if you will plan to access the CFIR tool, read the summary that we have on NCCMT of the tool, consider actually using the tool, or tell a colleague about the CFIR tool. So I see as people are responding, it seems like actually a really good mix that, and again, you can choose more than one answer, so you're not pigeonholed into just one answer. So it seems like there's a really good mix, of responses here with most of the people, participants today. Thank you for your responses, talking about accessing and reading the summary and considering actually using the tool in practice. So I think this is great validation, especially for us here at NCCMT, that these spotlight on web tools in our registry can be quite helpful to those to whom the tools are applicable. So we do have had some people post some questions for Laura, so I am going to go ahead and pose some questions to Laura, because we have lots of time here. We have at least 20 minutes for some questions and comments. So just a reminder to those of you to post your questions in the Q&A down below. We actually, I'm sorry, we are actually not on teleconference, only Laura and myself. So everyone, we would not have a chance to hear your questions via the teleconference line. But as I've mentioned, I can certainly pose them to Laura. So Laura, the first question from you is from Corinne. And she was curious to know why patients' needs and resources are considered to be a part of the outer and not the inner circle.
Yeah, that's a great question. I get that a lot. And frankly, when we were developing the CFIR, we very clearly recognized there were especially a few key constructs, patient needs and resources being one, compatibility being another, that really sit astride multiple domains within the CFIR. So the idea is that patients, I guess it's important to understand that the CFIR was developed specifically kind of with the world view or the world perspective of implementing programs or innovations into clinical settings. And the idea that patients are spend the majority of their lives outside of the healthcare system and really have very little interaction. We have actually relatively little opportunity to interact and to make, in terms of the hours of lives that are spent in the lives of patients. And the idea is that, first of all, it's important to understand that that construct is not just what are their needs and their resources, but also to what extent does the organization internalize, well, first of all, that they have an accurate assessment or perception of their patients, and also the extent to which they internalize that information. So in other words, the degree to which the organization is truly patient-centered. And so just because patient needs and resources is in the outer setting, it does not mean that they are not central and that they shouldn't be central to the organization. So I guess it's in the outer domain. I really, I don't have a strong rationale for that other than to acknowledge that it really has a place in both, a place in both domains for sure.
Great. Thank you so much, Laura. And Corinne, you can let us know if that has answered your question. And if you have any follow-up questions for Laura as well, we'll be happy to ask those of her. And Catherine would like to know, Laura, has this framework been tested for its applicability within an Indigenous context?
That's a great question. I do not know specifically. I do know that, well, and actually I'm not sure exactly what you mean by that question, and if it's because that may be a unique population, or if you're thinking of interventions or implementing or applying the CFIR within a community setting versus within a clinical setting, that there are several researchers who have applied the CFIR within a community setting. I know that they have applied it within highly constrained settings as well. In Africa, for example, there's been a couple of papers that have been published, or at least one, maybe two papers that have been published. If you go to our CFIRguide.org website, on the main page toward the bottom, there is a bibliography that we are trying to keep up to date, although it might be a little behind at the moment. But we have hundreds and hundreds of citations of the CFIR in that bibliography. And if it's actually searchable, and you can actually go in and see if there are any studies that are close to kind of a scenario that you have in mind with that question. And if you don't find anything, but you find that the CFIR resonates with you, and you think it may have applicability in your work and in that setting and with that population, then I would highly encourage you to, to publish an adaptation or recommendations about how to further refine and strengthen the CFIR to work within that realm.
Great, thank you, Laura. And to those of you joining us today, I've posted the link to that bibliography in the chat section, so the direct link to that is there. And I think, Laura, Catherine has just expanded a little bit, although she said, oh, okay, thanks. She was saying, she was just wondering more from a cultural context. For example, examining the framework within the context of different ways of knowing and worldviews. For example, has it been tested for its cultural competency?
Yeah, that's a great question. I'm not sure that the CFIR is necessarily equipped or designed to assess cultural competency, but I think that if you were, I know that there's a lot in the literature about the idea of cultural competency and other related concepts like homogeneity or, concordance, I guess, between the clinician and patient and with respect to race and ethnicity and language and culture. And those are all, I think those are all really important considerations, and the way to conceptualize that potentially is within the characteristics of individuals. So what are the characteristics of clinicians, and perhaps, and we have this kind of catch-all construct called other personal attributes. And one of the attributes that may be of particular importance, of course, would be the clinician's cultural competencies. And then to what extent, for example, if you're interested in implementing an intervention to improve cultural competencies of clinicians, then that's where you may look at the other contextual factors that may impede your ability to be able to do that.
Great, thank you so much, Laura. We'll give others and Catherine has replied great as well. So I am actually going to we'll give everyone a few more moments to try and see if you have any other questions or comments for Laura. And so just would like to invite everyone to complete a short survey about today's webinar, following the webinar. And it will help us improve the webinars that we deliver, and it will also help us to really get a sense of your needs and as such going on in the future. And I will post that in a moment, the direct link to that survey. And just wanted to remind everyone I had posted both of these links previously. So these are actually will be the links, and if you scroll up in the chat box, you will find the link to the audio and the PowerPoint that will be available after today's webinar as well. And so just, Laura actually, Catherine has actually replied after having said great, and I'm actually sure this is a question that people are wondering as well, because this was such a great presentation. But is there a way to contact you to discuss the presentation further relative to the question she specifically discussed? But I also think maybe for all of the other participants, you know, is there a next first step that you would also suggest that they might take? If they really were considering to use the CFIR tool, you know, is there another point of contact that they might get in touch with?
Well, first of all, I would strongly recommend going to the CFIRguide.org website. We have a lot of in-depth kind of guidance for and examples of different types of studies using the CFIR in different ways and different phases within the projects. And it would be really helpful to explore that. As other resources and other uses of the CFIR become known to us, we will continue to post to that website and continue to update it. There are places in the website that you can click on to contact for further questions or suggestions about how to improve the website, or I guess further elaborations that you may have about using the CFIR within your own work. Right now, I'm pretty much, you know, if you email me, I'm answering and responding as best I can. Sometimes I will refer them to other colleagues that I think would be able to really help out on that, so I can help in that, offer help in that respect as well. And I think that I would also just strongly suggest going to the literature. I mean, there are so many papers being published at a rate of multiple papers per week that cite the CFIR, and it's very difficult to keep up with them all. But if you just do, you know, a search either within our bibliography or within PubMed or even Google Scholar, and just to look up, you know, to see what the latest uses of the CFIR are, perhaps even in your particular area of interest.
Great.
But thank you for that question. I appreciate that. I really appreciate the interest, and you know, we try to, actually our group is increasingly able to offer technical assistance for projects, and we have ways of being able to consult or collaborate with you on your projects as well.
Great, thank you so much, Laura. And just before we wrap things up, I'll give again another moment to see if we have any more questions come in for Laura. But we will be having our next webinar on December 9th, 2015 at the same time, same place, and the Applicability and Transferability tool, a tool developed by the National Collaborating Center for Methods and Tools, but we will have user stories from those in public health who've actually used the tool in practice and adapted it as well. So the link to register for those in all of our webinars hosted by the NCCMT as well as our partner Health Evidence, I've posted the link to that in the chat as well. So I really don't see any further questions or comments coming up in the chat or the Q&A, so I would just like to take this opportunity on behalf of the National Collaborating Center for Methods and Tools to say thank you to all of you who have joined us today, and then a special thank you to Laura for joining us and giving us such a wonderful overview of the CFIR tool. And I will leave the last words with Laura. Do you have any last words of wisdom, Laura, for the group that's joined us today before we all get off the phone and get back to our day?
Just thank you very much for this opportunity to share our work, and I wish you all the best in yours.
Great. All right, everyone, thank you so much for having joined us today. You will see us still online while we wrap up a few things, but we thank you for joining us and look forward to having you join us again. Thank you.